I want to welcome everybody who's listening in. This is the second week of National Thrombosis Week, really National Thrombosis Fortnight. And this is the session that I've really been looking forward to. After a long time of COVID and VITS, this is a session that's trying to look forward and identify problem areas in thrombosis that need fresh ideas. So we've got three difficult areas in thrombosis, and I'm going to introduce each speaker in turn. So Narayan is going to talk to us about the difficult area where we're going to improve quality and safety in imaging for VTE. It's a real pleasure to work with Narayan Karunanithy. He is an extremely gifted intervention radiologist. And there's really nothing that he can't wire and improve outcome in thrombosis. So he's a wonderful colleague at Guy's and St. Thomas's. His subspecialty interests are venous and pulmonary embolism issues, and he also works with renal dialysis and transplant patients. He is the site lead, the PI for HiPETHCO and Optimize PE trials, which have looked at catheter-directed thrombolysis, and deputy CI for NIHR-funded multi-centered randomized controlled trials looking at the benefits of drug-eluting balloon angioplasty. So I'm going to let him tell us about what he thinks we should be doing in the future with imaging. Narayan, thank you.
Thank you for that kind introduction, Beverley, and thank you for the invitation. I'm hoping that you're able to see my slides.
Yes.
Great. Okay. So over the course of the next sort of 15 to 20 minutes, I'm going to focus really on two areas. One is imaging in acute pulmonary emboli, and secondly, imaging in acute deep vein thrombosis. There's clearly imaging does play a role in what happens as a sequelae of both of these conditions in the setting of chronic thromboembolic disease and chronic DVTs. But I'm going to focus here very much on what happens in the acute setting. And really, the first thing to say is that when we develop a deep vein thrombosis, and that can present in a number of clinical ways, either with leg pain, redness, swelling, edema, warmth, and tenderness. But the difficulty lies in that a number of other conditions can present with very similar symptoms. So a cellulitis or a hematoma because of a muscle sprain or a tear, or thrombophlebitis or even heart failure can present in very similar ways with regards legs. And the same is true also for pulmonary emboli. Typically, we would present with shortness of breath, chest pain, coughing up blood, loss of consciousness or syncope, tachycardia, heart beating fast, and hypertension. But similarly, a number of other conditions like myocardial infarction or heart failure can present in a similar way. So, and therein lies the importance of having a reliable way of having a diagnosis of venous thromboembolic disease. But the first question to ask ourselves is, does everyone need imaging? And the answer is probably not, based on a very thorough clinical decision making, and we can talk about this, which involves using the Wells score, for example, and a careful taking of a history, we can determine if a venous thromboembolic disease is likely or unlikely. And in the event that we have a low index of suspicion, a D-dimer test that proves negative may be adequate in excluding a deep vein thrombosis or PE. And doing it in this way, we know from studies published that we can reliably exclude a deep vein thrombosis in about 30% of patients, and in the setting of a PE, about a quarter of patients. But then nevertheless, a large vast majority where we are unable to exclude VTE do require more definitive imaging. And currently the standard of care for deep vein thrombosis is compression ultrasound, and for PEs is CT pulmonary angiograms. And this space though with imaging is evolving, and I just want to touch on the areas of these progress over the next few slides. So really the role where imaging plays sits in making sure we have a reliable and importantly safe way of diagnosing DVTs or PEs. But imaging goes beyond that. It really can help us now in providing information on the severity of venous thromboembolic disease and hence guide the therapeutic decision making that we need to go through when we diagnose a patient with a DVT or a PE. So with regard to deep vein thrombosis, as I said, a duplex ultrasound forms the mainstay of investigation in the first instance, but increasingly magnetic resonance venography or MR venography is playing an important role, and I'm going to focus in on where those important rules are. So duplex ultrasound has been well established for the diagnosis of deep vein thrombosis, particularly those deep vein thromboses that occur at and below the level of the inguinal ligament. So anything in your thighs, behind your knee or in your calf veins, it does have a very good diagnostic ability. However, the diagnostic accuracy is very much dependent on the operators. There's been fantastic technological progress in the types of probes we can use and the quality of the machines, but the rate limiting factors remains the operator dependent accuracy of the deep vein thrombosis. And there are certain times when it can prove difficult, especially when clot extends above the inguinal ligament up into the iliac veins, or if a patient has a high BMI. Those instances can prove difficult to diagnose with ultrasound alone, and also in the setting of an isolated calf vein occlusion. But the benefit of ultrasound goes beyond the binary decision of is there DVT or is there not DVT. We know when we look at veins in the legs, we have different sets of veins, and we have our deep veins, obviously, which could become thrombosed. But then there is a superficial venous system as well, and there is an interaction between the two venous systems, which we need to appreciate on a patient by patient basis. And beyond there being the presence of deep vein thrombosis or not, we know that the veins have valves and function. And the ultrasound again provides very good assessment of the functionality of the valves, if there is incompetence or not in particular, and is that related to the deep veins or the superficial veins. So it's important to appreciate that the ultrasound goes beyond just a binary decision making of is there DVT or not, and provides very important functional information which the other imaging modalities may not be able to provide as well. So in where MR venography comes into acute deep vein thrombosis is when the duplex ultrasound proves to be inconclusive, and various studies, especially with the very newer sophisticated MR venogram protocols, indicate a very high sensitivity and specificity for diagnosis of deep vein thrombosis. And this is a typical example from our practice from only a few weeks ago. This is a young patient of 13 or 14 who had debilitating left leg pain. And this is these are cross-sectional axial images taken through the lower part of the thigh, which show on the left here the artery with two veins on either side of it. And just on the level below that, we can see here where the arrow is pointing at the focus where there is bright clot within the vein, and that in a vessel that's only probably about 3 or 4 millimeters, we're able to get very high resolution images that are able to diagnose very confidently the presence of a deep vein thrombosis. And so, and But beyond the diagnosis of deep vein thrombosis within leg veins, there are important management considerations which imaging can help with as well. We do know that there is an increasing trend towards managing patients with iliofemoral deep vein thrombosis, in particular with catheter-directed thrombolysis. And when there are patients being considered for that, the MR venography comes into its own in providing incredible amounts of information, which are really helpful in guiding treatment. For example, it'll tell us what the proximal extent of the thrombus is, how much about the inguinal ligament does it extend? Does it extend into the inferior vena cava? Are there any anatomical variants, like there is a small percentage of patients in whom the IVC may be absent, or we may have 2 IVCs? All of these are really important information to take into account. It also provides information on any coexisting abdominal or pelvic pathology. And importantly, the MR venography can give us an indication of the thrombus age, because we know that patients do very well with catheter-directed thrombolysis when the thrombus we're treating is very fresh, typically less than 14 days old. And I'll just show you some examples of that in a minute. The protocol we use is a very standard technique of acquisition, which is available on any MRI scanner. So this doesn't involve any special purchases of additional packages, for example. It can be done on pretty much every single MR scanner up and down the country. The additional benefit is because we're using the patient's own inherent contrast, as it were, within their veins, it's not dependent on flow, which is important for venous imaging. And importantly, it's also a very quick scan. It only takes about 7 to 10 minutes. It importantly doesn't involve any ionizing radiation, and it doesn't involve any administration of contrast agents, which may have either allergic or other consequences for the patient. And so these are the type of images we acquire here. And what we're seeing here is a patient who presented with a very swollen left leg. And on the right, you can see a very nice patent common femoral vein. But on the left side, you can see that this vein is distended, has occlusive thrombus within it, and there's quite a lot of edema within the vein wall and within the subcutaneous fat. And this is typically what we see in a patient with acute deep vein thrombosis. Those arrows just point out the normal vein on the right and the abnormal vein on the left. This is another patient who presented also with a left leg swelling, and again we can see the thrombus within the left common femoral vein. But when we scanned higher up, we could see that here this patient has where we'd expect to see an inferior vena cava next to the abdominal aorta. There's a very small little channel. So this is a patient with IVC atresia, and we can appreciate lots of collateral veins that you may see if you were to examine this patient. And so this patient clearly had an iliofemoral DVT, but had an underlying IVC atresia also. This is yet another example of a patient who presented with a very swollen left leg, and again, similar to the previous cases, has a very occlusive thrombus within the common femoral vein with marked swelling in the vein wall and in the subcutaneous fat. But unfortunately here, we discovered when we looked at this patient that they had a mass lesion within the body of the pancreas, and on further imaging had multiple lesions within the liver. So this patient who presented with a DVT, where it was their way of presenting with metastatic pancreatic carcinoma, and the MR imaging helps sort of unpick that in this case very well. As I alluded to, if you're considering more advanced treatments like catheter-directed thrombolysis, an appreciation of the thrombus age is very important. And this, again, you can get from the appearance of the thrombus within the veins on MR. And you can see here a vein which has got that thrombus and quite a lot of edema in the vein wall and in the subcutaneous fat. As it evolves, this is very much on the other end of the spectrum, a chronic case where there is a small vein with scarring within it and lots of collateral vessels around it. And that clearly indicates for us that this thrombus is much further along in progression. A quick word about CT venography. It is performed and there are definite advantages in terms of availability and diagnostic accuracy, but you do have to bear in mind that often patients who present with deep vein thrombosis are very young, and there's a clear radiation exposure, especially if you're scanning the abdomen and pelvis in these young patients, which has to be borne in mind when imaging these patients. I'm going to, in the interest of time, skip past this next slide, except to say that in addition to the non-invasive imaging techniques that we do use invasive imaging techniques, and in particular intravascular ultrasound. Essentially, here you get an image of the vessels using ultrasound rather than it being out on the skin surface looking into the vein. This is you get the ultrasound on a catheter probe. We're sitting within the vein lumen itself, looking out onto the vein wall. And this is what it looks like when you look at a correlative image from an MR venogram, where you see a vein with some scarring. And on intravascular ultrasound, you have the scars going through it as well. And I'm glad that fire, it was just a test. And this is what we do when we do a pullback of the intravascular ultrasound. It just it gives you really exquisite information about what the vein looks like from the inside. But there are limitations to cross-sectional imaging. It doesn't provide the hemodynamic information that duplex ultrasound can provide, or the evidence of venous reflux that a duplex ultrasound can provide. And so moving on to from deep vein thrombosis to acute PEs, again, the ask from imaging here is to reliably able to diagnose pulmonary emboli and provide an indication again on the severity of the pulmonary emboli, which helps us to risk stratify our patients so that they can be managed appropriately. Here, within acute pulmonary emboli, CTPA forms a mainstay of imaging, but increasingly ventilation perfusion scintigraphy, and there are two techniques I'll describe in a minute, are increasingly becoming useful because they are safe, they are reliable, and have significant advantages. So firstly, with CT pulmonary angiograms, it is widely available and provides excellent diagnostic accuracy, and in addition allows the assessment for right heart strain, which becomes an important factor when we're dealing with the more severe end of the spectrum when it comes to pulmonary emboli. But nevertheless, it's very important to bear in mind that there is an ionizing radiation exposure and administration of contrast, which can have consequences in terms of its effect on the kidneys and possible allergic reactions also. And this is typically what we see when we do CT pulmonary angiograms. You can see that there is a thrombus within the right pulmonary artery here. Even when they go into segmental branches or the smaller dividing branches, you can very nicely appreciate that there is thrombus extending into that right segmental pulmonary artery. In addition, we get to look at the heart, which gives us information about the degree of right heart strain. And this view here shows the right atrium and ventricle and the left atrium and ventricle. And we can see clearly here that the right ventricle is larger than the left. There's flattening of the interventricular septum, which clearly indicates that there is that the right heart is under strain. Another indicator that there is right heart strain is you have, when you administer contrast, rather than go into the right atrium and ventricle, it's refluxing out into the IVC and into the hepatic veins. And again, that gives us an indication that there is right heart strain. And the importance of appreciating the right heart strain comes down to the treatment algorithms when it comes to pulmonary emboli. Most patients with pulmonary emboli do not have right heart strain, and then would be classified as low risk PEs, and their management would invariably be on an outpatient basis with anticoagulation alone. But once you start to see the presence of right heart strain on CTPA or echocardiography, and you measure other parameters like cardiac biomarkers, it pushes you further along in terms of the severity end of the spectrum from intermediate low to intermediate high, or onto when you have blood pressure compromise, which is the higher risk PEs. And the treatment algorithms then change from management to potentially more invasive forms of treatment. And so being able to risk stratify these patients helps them to be managed in a safe way. And that's the ESC guidelines on the risk stratification, which I just touched on. So the evolution from CT pulmonary angiography is dual energy CT pulmonary angiograms, which, in addition to providing information about the vessels itself, produces perfusion maps, which I will show you, and these have become incredibly useful to do. This is a patient with a segmental thrombus within the pulmonary artery, which, when we did the iodine map, shows up as an area of reduced perfusion on this dual energy CT scan. So we get an appreciation of the the volume of lung which is hyperperfused as a result of the pulmonary embolism. This is another patient with what we call a saddle pulmonary embolism, where there is a thrombus within the main pulmonary trunk, which is extending across the bifurcation of the main pulmonary artery into both the right pulmonary artery and the left pulmonary artery. And you can see on the axial image, again, this patient has quite established right ventricular strain, and you can very quickly appreciate the areas of hyperperfusion that's been caused by the pulmonary emboli in this patient on both the coronal and the axial images. So moving on from CT pulmonary angiography, like I said, ventilation perfusion scans have been around for a long time, but the more traditional way of doing it was a planar 2D ventilation perfusion scans. And the more newer scans are the SPECT CT scans, where it combines the ventilation perfusion maps with a CT scan of the chest, which gives us even greater spatial resolution, and which in turn gives us much better confidence in diagnosing pulmonary emboli. And in addition, it gives us an ability to assess the lungs for additional pathologies like emphysema or pneumonia, or more recently, the amount of COVID pneumonia, for example, the degree of lung parenchymal involvement. And this has shown very high sensitivity and specificity in studies that have been published already. And so this is what we see. We very much appreciate on the segmental perfusion defects, which, when we look at the CT scan, doesn't show any lung parenchymal abnormalities. So there's clearly a ventilation perfusion mismatch, which is what typically a pulmonary embolism would look like. So I'd like to draw to a conclusion then to say that emerging techniques, as I've described, have allowed for safer and more reliable diagnosis of VTE. In the case of deep vein thrombosis, MRV venography has become more useful. However, it's not to replace compression ultrasound. Compression ultrasound done in the right hands still has a very good sensitivity and specificity for deep vein thrombosis. In the field of PE, SPECT CT, especially because of its much lower radiation dose, but also dual energy CT pulmonary angiography, are becoming more widely used and provide more nuanced information with regards to the management of these patients. And clearly, imaging in general is playing a more important role in determining the management strategy, especially for high-risk clinical scenarios. Thank you very much.
Thank you very much, Narayan. That covered everything. Could you, before we move on, just tell everybody what dual energy scanning actually means? It's a new term, and I'm not sure everyone is fully clear what's going on when the scan's done.
Yeah, so the patient's still on a CT scan, and simultaneously we acquire the same data, i.e. through the chest, in a low energy setting and a high energy setting. And once we've got those two sets of images, we put them together. And that gives us a virtual perfusion map, because we know what the scan looks like with no contrast, and we know what that area looks like with contrast. So when we subtract the two bits of information from each other, what's left is what's enhanced as a result of the contrast, which is a perfusion map, which is what it looks like on those beautiful sort of images with the color on, which gives us real indication of where the perfusion defects are for these patients.
Thank you. And the color reflects the level of perfusion, does it?
Exactly. So the more brighter the red or orange, the more well perfused it is. And when there is loss of, when it looks more black, that indicates that that area is not perfused at all.
Excellent. And then really, I wanted to ask you the horrible question around diagnosing pulmonary emboli in pregnancy. At the moment, we don't really have any biomarkers we can use to say, oh, you don't have a pulmonary embolism. So almost everybody's going forward for scanning. We are offering ventilation perfusion scanning or with SPECT or CTPA. Which do you think is going to be the better in the future?
I really think that's a very difficult cohort of patients, and
I'm
we really
sorry.
hope. No, you're absolutely right, and we'd really hope that the study that you published last year would, cast us more information on the use of biomarkers. With regard to imaging, I think really perfusion imaging, where essentially we where we only get subject the patient to the perfusion image, which is a much lower radiation dose, would be by far the better way of travel, rather than subjecting these patients to a CT pulmonary angiogram. Availability across organizations is a rate limiting factor at this stage, but we very much hope that would change, and with evolving technology, I certainly think that ventilation perfusion imaging is going to be the mainstay of imaging we hope in the very near future.
We have Professor Helen Philippou. She's Professor of Translational Medicine in the Faculty of Medicine at the University of Leeds, and she's founder director of LUNAC, which is developing a next generation oral anticoagulant with minimal risk of bleeding, i.e. the near perfect anticoagulant, which is what she is here to talk to us about. She's an international leader in research, in thrombosis. She sits on the editorial board of RPTH. She's an advisor to next year's ISTH in London next July, and she's co-chairs the scientific subcommittee of the ISTH for Factor 11 and the contact system. Previously, she's chaired other sections. So she's very well qualified to talk to this on this subject, which is trying to move towards the near perfect anticoagulant. Helen, the stage is yours.
Thank you very much, Beverley and Joe, for this invitation. So as Beverley's mentioned, I'm a founder of LUNAC Therapeutics that's developing factor 12A small molecule inhibitors. So to set the scene, I don't really need to this audience, but thrombosis is a very large problem affecting up to 87 million. And of the patients that have atrial fibrillation, to prevent their risk of stroke, only 70% are actually receiving anticoagulation, meaning that 30% are remaining untreated. And generally, with anticoagulant use, up to 20% of patients are still having a bleeding event. Now, because of the need to balance prevention of thrombosis without incurring a risk of bleeding, these patients are not optimally anticoagulated, which means that there are still up to 4% of patients having a thrombotic event. So the idea of having an anticoagulant that can address the bleeding risk will then also could potentially address the actual unmet need of the thrombotic events that are still occurring even if patients are on anticoagulation. So this is a schematic of the coagulation cascade. We have the intrinsic pathway, the extrinsic pathway that ultimately give rise to thrombin that can cleave fibrinogen from a soluble plasma protein into an insoluble fibrin mesh that becomes the scaffold of the blood clot. Now, the current oral agents that are on the market are targeting the common pathway. So there's dabigatran that's targeting thrombin, and then there's 4 agents on the market that are targeting activated factor 10. So just a recap. So the unmet need at the moment with anticoagulants are that we're having both the bleeding risk, and because of the need to balance the prevention of thrombosis with bleeding, we're also still having patients that are having thrombotic events despite being on anticoagulation. So next slide. So this is a general overview of the coagulation pathway. You have the intrinsic pathway and the extrinsic pathway, and the current agents that are on the market target the common pathway. And the common pathway is involved in both the formation of pathological thrombosis, but also the stemming of bleeding. And that's why we have this balancing act of trying to balance the optimal dose for anticoagulation. And the current targets are thrombin, where we have dabigatran, and then the 4 factor 10A inhibitors. And in the pipeline, there's developments towards targeting activated factor 11 or factor 11 and activated factor 12. Next slide, please. So just to give you an understanding as to why the intrinsic pathway is now being targeted, historically, it was thought that factor 12 didn't play a role in thrombosis, and this was partly because factor 12 deficient individuals didn't show a bleeding phenotype, and therefore it was considered that if the patient's not showing bleeding, then factor 12 is not involved in thrombosis. However, in 2005, Dr. Thomas Rene showed that in factor 12 deficient mice, they were unable to form thrombi. And so if you look at the factor 12 knockout mice, you can see that there's no thrombi compared to the wild type mice. And this was also true for factor 11 deficient mice. Next slide. And what was interesting about this was that although these mice did not actually form thrombi, they didn't have a prolongation of bleeding time either. And so this was the first time it was possible to consider targeting factor 12, because in this situation, you'd be able to inhibit pathological thrombus formation, but not potentially incur bleeding risk. And on the graph at the bottom, you can see that bleeding time experiments that were performed in wild type mice, in factor 12 deficient mice, and mice that were administered heparin, where there's a prolongation of the bleeding time. So next slide. So clinical validation for targeting the intrinsic pathway has been shown by an antisense oligonucleotide that prevents the formation, inhibits factor 11 being generated in humans. And in this study that was carried out by Harry Buller and co, they showed that at a dose of 200 milligrams or 300 milligrams of this antisense oligonucleotide, only 3% of the patients were having the principal safety outcome of major or clinically relevant non-major bleeding. And this compared to 8% of patients that were on enoxaparin. And what you see is that if you knock down 68% of factor 11, there are still 27% of thrombotic episodes. Whereas if 83% of factor 11 is knocked down, this got reduced down to 4% of thrombotic episodes. And this compares with enoxaparin, where there was 21% of thrombotic episodes. Next slide, please. So that provided the clinical validation that targeting factor 11 could actually prove clinically beneficial. And with respect to the preclinical validation of targeting factor 11 or activated factor 11, the evidence comes from the fact that factor 11 knockout mice have reduced thrombus formation with no potential prolongation of bleeding time. Factor 11 can be knocked down in primates, and this prolongs the APTT time and reduces venous thromboembolism in the study that was just mentioned. And inhibiting activated factor 11 using antibody approaches also results in a reduction in thrombus formation in murine models, and this is associated with in primates a prolongation of APTT. And there's a small molecule that's been developed by BMS, and on this particular molecule that's been published, 80% inhibition was observed at a dose in arterial thrombus formation in rabbits, but which actually was associated with a 1.5-fold prolongation of bleeding in this particular model. So this is better than the 10A inhibitors. And the other evidence is that factor 11 deficiency in humans is mild. There's a mild bleeding phenotype that's usually incurred upon a trauma. Next slide. So what about the preclinical validation for targeting activated factor 12? So as I just showed, factor 12 knockout mice have reduced thrombus formation with no prolongation of bleeding. And if you infuse factor 12 back into those knockout mice, you can restore the thrombus formation, suggesting that it is as a result of factor 12. And if you inhibit factor 12, activated factor 12 with antibody or protein approaches, again, you see reduced thrombus formation with no prolongation of bleeding time in various animal models. And if you inhibit factor 12 activation in a baboon model, you also see reduced thrombus formation. And therefore, targeting factor 12 is predicted to allow for a wider therapeutic window than the other agents, because there's a wider inhibiting it was unlikely to result in bleeding, and therefore you could go up to higher dose to ensure that you achieve the efficacy required. And as the human validation is that factor 12 deficient individuals are asymptomatic with no bleeding tendency, which is unlike all the other coagulation factor deficiencies. Next slide. So at the moment, there are several approaches in development that are targeting factor 11 or its activated form. There's the antisense oligonucleotide that I just mentioned, and this is currently in phase 2. It's quite unclear to understand what the actual indications that they're going for. As far as I knew, that they were going for end-stage renal disease. But when you look at the databases, venous thromboembolism is coming up, but not the end-stage renal disease. And yet, if you look at the Bayer website, it's looking like it's end-stage renal disease. So I'm not quite sure on what the indication is that they're actually going for. And then there's 2 other antibody approaches that are being developed, one by Anthos Therapeutics in phase 2 for the prevention of stroke and for arterial thrombosis, and also for prevention of venous thrombosis. And then there's the Bayer that are developing an antibody. And these indications are end-stage renal disease, venous thromboembolism. And sorry, there's a third one as well, Arona, that's in preclinical development targeting factor 11. So with respect to small molecules, there's 2 currently that are quite advanced in large pharma. There's one by Bayer, and the indications that they're going for are myocardial infarction and ischemic stroke in atrial fibrillation patients. And then there's the BMS, who've partnered with Janssen, and they're looking for the indications of thrombosis and venous thromboembolism and acute ischemic stroke. And I understand that that's also secondary prevention of stroke. Next slide, please. So with respect to factor 12, there are currently two approaches that are acknowledged. There may be other work going on in the background, but I've only noted ones that are going for anticoagulant indications. So there's an antibody being developed by CSL Behring that the initial indication that they went for was hereditary angioedema, and that's actually just recently been approved by the FDA. And they're also looking at using this antibody in patients with COVID-19. So there's trials underway at the moment. Lunac Therapeutics is developing oral small molecule inhibitors at the moment, and they're in preclinical stage. Next slide. So a new angle of coagulation was fairly recently identified back at the ISTH in Melbourne in 2019, when we could all still get together. We presented a poster along, and we actually found that there were two other groups just on either side of our posters that suggested that kallikrein could activate factor 9 in a manner that bypasses factor 11. And interestingly, all of these groups came to a similar conclusion by using different approaches. All these papers have now been published. I'm just going to give you a bit more detail as to what our study showed. So next slide. So the view that as it stood back then was that kallikrein could only be responsible for in coagulation with respect to generating thrombin via factor 12. So in other words, kallikrein cleaves factor 12 to its activated form. Factor 12 then cleaves factor 11, and they're thereby starting the generation of thrombin. Next slide, please. What we found when we did thrombin generation was that kallikrein was actually able to generate thrombin in the absence of factor 12, which is observed in panel B, and factor 11, which is observed in panel C. So this meant that the route that kallikrein was completely only working through the activation of factor 12 doesn't hold true. What you see is that, and below, is that there was delayed kallikrein generation in factor 9 deficient plasma, and this didn't happen at all in factor 10 or factor 9 deficient plasma when CTI was added. Next slide, please. So then we looked at whether kallikrein was able to form thrombin, fibrin rather, and this is a turbidity assay. And what you see is as clots forming, you see the line going up and then it plateaus out when the clot's formed. What you can see in normal plasma is that as you add increasing concentrations of kallikrein, you can see that you form your clot, and it's time dependent. And in factor 12 deficient plasma, it was still possible to form clots as it was in 11 deficient plasma. So again, supporting this idea that kallikrein must be acting by an alternative mechanism. Next slide, please. So we looked to see whether pre-kallikrein and kallikrein could actually bind to factor 9. And what we see is a very tight interaction where factor 9 is able to bind to pre-kallikrein and kallikrein, and activated factor 9 is also tightly bound to pre-kallikrein and kallikrein. And these curves are generated with a different SPR system. So these are kinetic curves, and the concentration of the analyte is increased in the association phase, but this isn't evident in these curves, but it is kinetic data. Next slide, please. So what this suggests is that kallikrein, and if you look at the red line, kallikrein can actually activate factor 9 directly. And we've gone on to do a lot more analysis that I won't take you into the details of now, and characterize this with kinetics, and actually shown that this kallikrein activation of factor 9 is likely to be physiological at physiological plasma levels of these proteins. So this suggests that the kallikrein can do things that hadn't been appreciated before within the coagulation cascade. Next slide, please. So if we what this means is that if you target factor 12, ultimately you're reducing the amount of kallikrein generation because factor 12 converts prekallikrein to kallikrein. So therefore, if kallikrein can activate factor 9 and bypass factor 11, it's going to be interesting to observe the clinical observations that we will see from the clinical studies targeting factor 11 and factor 12, because it might be that the efficacy may be slightly different in different clinical scenarios. And so what this is actually saying is that, you know, there is now a suggestion that this mechanism within the coagulation cascade may be targeted by 12 inhibitors, but not 11 inhibitors. However, 11 inhibitors do have efficacy, and we know that. So it's going to be really interesting to understand what comes through from the clinical studies. And it's likely that there'll be a niche for both 11 and 12 inhibitors with potentially separate indications. Next slide, please. So the future is holding a paradigm shift in anticoagulation, where it may be possible to actually achieve antithrombotic efficacy with reduced risk of bleeding. Next slide. So I'd be really interested in the discussion to hear your opinions on which clinical indications you think may benefit from anticoagulants with minimal risk of bleeding. Next slide, please. So I'd just like to thank the key people that are involved in the kallikrein story, and they're circled here, and Colin Longstaff as well for his key input into the kinetics. And with respect to our drug discovery, we've got too many people to mention, but I'd like to thank everybody that's been involved and all our funders as well. Thank you very much.
Fantastic, Helen. Thank you very much. So I'm just thinking ahead to ISTH 2022 next year in London, which I hope everyone who's listening is coming to. What are we going to be talking about then? Will some of the clinical trials be through by then?
Hopefully. So the BMS and the Bayer 11 studies, they're in phase 2 at the moment, and there've been some of them. The BMS one's been there for a little while, so hopefully we hope to hear what the outcomes are there. And yeah, as other things progress, maybe we'll get to see more of the preclinical data.
Any predictions?
Well, all right.
You're allowed to be wrong,
My prediction is that for the 11 inhibitors, I think it's going to be really crucial the dose that's given, because my concern is whether they give enough to achieve the efficacy. Because if you see from the antisense oligonucleotide study, there was a very narrow window of achieving efficacy if they, and you have to hit that threshold. And if that threshold is being hit, it would be good. If it's not, then there may not be the efficacy that they were hoping for.
Okay, well, thank you very much. We'll move on and we'll come back to you at the end. So we're moving on, and we're going to move on to Professor Roopen Arya, who almost everybody, in fact, everybody on the line must know. He's going to talk about improving VT risk assessment for thromboprophylaxis in the UK. He couldn't be better qualified to talk about this. He is the clinical lead for National VT Prevention Programme at NHS England. He's director of the National VT Exemplar Centres Network, has overseen establishing 36 VT Exemplar Centres to date. He is also a lead clinician and deputy clinical director in haematology at King's College Hospital, and he has a lot of research interests in venous thromboembolism, especially in this area. So Roopen, the stage is yours. Thank you very much for talking today.
Thanks, Beverley. Thank you for the very kind invitation to speak today on the occasion of National Thrombosis Fortnight. I think that kind of partly reflects the success of Thrombosis UK in promoting this cause. And the topic you've given me is a very difficult one. Where next with VT prevention? How can we improve VT risk assessment for thromboprophylaxis in UK hospitals. I think this is an area that for the past decade has been relatively stagnant in that, as far as the choice of anticoagulant goes, I think it's true to say that low liquid heparin still hold the stage. And so I think what Helen spoke about was of great interest to us. And again, I think the risk assessment models and strategy have not really changed in the past decade. So I shall talk about how we developed a systematic approach, the results of the recent curved survey, and the limitations of our current approaches, and how we might look to improve in the future. So again, by the way of headlines, we know venous thromboembolism is common, with nearly half the events associated or attributable to hospitalization, with an in-hospital incidence of nearly 2%. And that appropriate thromboprophylaxis reduces the risk of venous thromboembolism by 50 to 60%. And certainly for the past decade or two, there has been a recognition that prevention of VTE is a top clinical priority in our hospitals. So in 2010, a national VTE prevention program was launched in England. And I think the mainstay of that is a uniform and mandated and documented risk assessment process, because we know that risk assessment is the trigger for the VTE prevention pathway, because the figures have been collected nationally via the Unify data collection. But until recently, we had an incomplete oversight of the rest of the pathway, whether it was counseling the patients or prescribing appropriate thromboprophylaxis. Quite early on in the process, mainly as a result of the financial driver associated with Sequin, most trusts achieved the 90% risk assessment target for VTE, which then morphed into a 95% target. But throughout this time, we were unaware of the quality of the risk assessment or whether patients got thromboprophylaxis as appropriate. And it became apparent a couple of years ago that standards were also slipping and that many hospitals were unable to reach the target in 2019. There's no national data on thromboprophylaxis use per se, but expenditure on low liquid heparin used for prophylactic doses is a useful surrogate marker. And unsurprisingly, this has gone up in recent years. Also, I think for the first time in any healthcare system globally, we were able to demonstrate an improvement in patient outcomes with a 16% reduction in post-discharge VTE deaths in the past decade, which I think is a considerable achievement. But we were aware that there were issues about a considerable ongoing burden of hospital-associated thrombosis, which was reflected in our local data, as well as the rising litigation costs around hospital-associated thrombosis, which over a 5-year period was nearly £90 million. So about 3 years ago, a group of us clinicians, as well as Thrombosis UK, the Exemplar Network and GIRFT got together and resolved to address this through the GIRFT thrombosis survey. Now, the aims of this survey was to examine the variations in the organizational approach to VTE prevention, to look at the whole VTE prevention pathway, and also look at hospital-associated thrombosis, the numbers of cases, how many were potentially preventable, and were there any common themes. We had over 100 participants nationally in England. And The organizational survey threw up many interesting findings. Nearly a third of the hospitals did not have a VT prevention role, which was worrying. The majority of hospitals, but not all, identified cases of hospital-associated thrombosis, and nearly 90% of hospitals still used the National VT Risk Assessment tool, remembering that the latest NICE guidance does allow the use of other published tools. And unsurprisingly, because I think the VT prevention processes are now well embedded in the NHS, there was an 80 to 90% appropriate thromboprophylaxis rate, albeit with variation at the individual sites. What was worrying was that overall, with about 8% of the cases, missed doses of anticoagulant prophylaxis were a significant problem, and really reflecting what we know from the root cause analysis program and from the adverse incidents that we see. And we also remain bad at providing patient information, which is a key part of patient care, patient awareness about venous thromboembolism, and also the encouragement of compliance with thromboprophylaxis. So the HAT survey included nearly 4,500 episodes of hospital-associated thrombosis. Now, this program is something that I'm absolutely passionate about because it reflects the true burden of hospital-associated thrombosis locally. It helps identify problems as well as enable solutions to be found. But on the other hand, the number of hospital-associated thromboses is not necessarily a good marker of quality because there's an inherent ascertainment bias. Centers with an interest in VT prevention are more likely to also identify cases. But I think this is a very important learning that ensues that is valuable, both in identifying themes as well as common solutions. The highest rate of hospital-associated thrombosis is in medical patients, and there's considerable variation between the sites in terms of absolute numbers, which is something we need to address. And unsurprisingly, again, this HAT survey revealed deficiencies in risk assessment as well as the provision of thromboprophylaxis, which contributed to hospital-associated thrombosis cases that were potentially preventable. So in summary, the Gulf Thrombosis Survey, the results of which will shortly be published, provides the first insight into real-world VT prevention practice. And I think this is an area in which we have led the way globally in standardizing VT prevention, but a significant variation in VT prevention practice still prevails. So how do we improve our practice? Again, from some of the data that I've just shown you, one area that was highlighted was the role of VT risk assessment. And also we were bad at repeating the risk assessment because the patient pathway in hospital is a very dynamic one with changes in both thrombosis risk as well as bleeding risk. So there are many scenarios in which we might need to risk assess for venous thromboembolism, whether it's on admission to hospital or in the surgical pre-assessment clinic, whether it's on discharge, in pregnancy, in cancer patients, or whether it's on primary care. So which risk assessment tool should we use? Again, quite early on in the process, over a decade ago, there's a realization that the tool needed to be accurate and easy to use with good discrimination between the risk groups and something that could be widely applicable and directly linked to recommendations for thromboprophylaxis. And I think most importantly, I think also to be clinically validated with an evidence of efficacy. with regard to clinical outcomes, and also to be cost effective. So there are many, many risk assessment tools that have been developed over the years. Quite early on in the process, there was the ACCP guidance in the kind of group led by Bill Gates at the time. And then the NHS risk assessment tool, again, it was derived over 10 years ago. And covering a population of both medical and surgical patients. And both these examples provide a qualitative approach to risk assessment, which is very much derived from expert consensus, and they have not, unfortunately, been externally validated. Then in medical patients, we saw the derivation of the Padua and the IMPROVE scores that were in medical observational cohorts of medical patients and resulting in a kind of weighted scoring system. And this has been signposted in many guidelines, including the ASH guidelines. The Caprini risk assessment tool, again, is widely employed globally, though is found by some to be overcomplex, with, I think, 39 criteria in the slimmer version and 89 criteria in the complete version, but also found in 1 or 2 studies to assign many more patients to the higher risk categories. In one study, nearly 82% of patients were assigned to high risk category, compared to the Padua scoring system, where 30% were assigned to a high risk category. So really, the important question is, which one is right and which one has been adequately validated. Some of these tools, I think, arose as part of the enthusiasm for post-discharge medical thromboprophylaxis using the direct oral anticoagulants, where the trialists sought to enrich the trial population for risk by using tools such as the IMPROVE tool, allied in some cases to biomarkers like the D-dimer. And there have also been niche risk assessment tools addressing specific patient groups like cancer patients or lower limb immobilization or pregnancy, or even the primary care population. So it is important that we get the process of risk assessment right, because overuse or underuse can result in an increase in adverse events such as bleeding or thrombosis. Unfortunately, the variability in how these tools are derived or validated or not limit the comparability between the tools. And there's just a handful of studies that assess the impact of these tools in clinical practice on the outcomes. There were, in the past 2 or 3 years, 3 or 4 studies that generally did show an improvement in the thromboprophylaxis rates as well as a reduction in VTE rates. So the national VTE prevention tool in England has been with us for over a decade, where all surgical patients are risk assessed and medical patients if they're deemed to have reduced mobility. But unfortunately, despite the widespread use, probably now in millions of patients over the years, we are not in a position where we are able to validate this tool, because a single tick box for risk of thrombosis or risk of bleeding drives an action, and generally those who were filling in the risk assessment tools, I think, lost the enthusiasm after ticking one box. So we got an incomplete picture of the real risk on an individual basis. But I think there's little doubt that the widespread and mandatory adoption of this risk assessment tool has driven the thromboprophylaxis process with some evidence of improved outcomes, for example, with the post-discharge VT deaths that I had demonstrated earlier. So at a local level, we have seen year-on-year improvement in the number and cases of potentially preventable hospital-associated thrombosis. We did initially, after applying this tool, see a significant fall in the total rate of hospital-associated thrombosis of about 12 or 13% after we hit the 90% risk assessment target. But we have continued to have a substantial burden of hospital-associated thrombosis because the numbers seem to have leveled off. So the limitations of the current process is that it remains a tool based on expert consensus, which has not been formally validated. Some people feel that the tool is over-inclusive because over 80% of medical inpatients, for example, qualify for thromboprophylaxis. I think there's a big question around cost effectiveness. There's a lack of data regarding the adverse outcomes, and this is, I think, one of the favorite questions posed by the surgeons, if that we have very little visibility of the bleeding outcomes as well as the wound infections in these patients. So despite the increased and widespread use of prophylaxis of the past decade, we have limited data of the impact on the outcomes. So there is an important ongoing study from Steve Goodacre and his group in Sheffield, which does involve Beverley and many other co-investigators, which is funded by the NIHR, which are examining the cost effectiveness of VT risk assessment tools for hospital inpatients. And they're using a combination of systematic reviews, decision analysis modeling, and looking at the potential of a feasibility study of these risk assessment tools, which should hopefully inform the NICE guidance and also future prophylactic approaches. So next, I'm going to focus on orthopedics, which is a particular high-risk area for hospital-associated thrombosis. It is an arena in which the first trials of thromboprophylaxis originated half a century ago. And orthopedics is also the testing ground for all the new anticoagulants. But once they have kind of demonstrated anticoagulant efficacy in this setting, most pharma companies move on to, the bigger prize, which is, the 2% of the population with atrial fibrillation, a substantial proportion of which need to be anticoagulated. So how do we make risk assessment more meaningful in this setting? Now I'm going to share in the next few slides some of the collaborative work we have been doing with Leiden Group, led by Suzanne Kanegeta, as well as very enthusiastic and bright young orthopedic surgeon Banner Nemeth on VT prediction in the orthopedic setting, which also I think is an exemplar of how we need to individualize the approach to thromboprophylaxis across the board. There's been a shifting landscape in orthopedics from an initial population-based approach where the surgery attributed risk far outweighed the patient-specific risk factors and really was sufficient to guide the prophylactic approach, to a more tailored, individualized approach where the patient risk factors for both VTE as well as bleeding are taken into account in addition to the surgery to help guide thromboprophylaxis. Clearly, there has been a big shift in VTE incidence in recent years, and also, I think, a move from venographic outcomes to symptomatic outcomes, which are felt to be more meaningful. So one of the reasons for this enormous decline in VT incidence is the use of the various anticoagulants in this setting, though I think the mainstay of prophylaxis remains low molecular heparin. But some of the newer agents that Helen described, I think, are already being looked at in this setting. So I think the further improvements can be attributed to better surgical care and early mobilization and improved post-surgical patient care, such that even without the use of prophylaxis, the symptomatic VT rate's about 3.5%. However, despite the use of the current state-of-the-art prophylaxis, 1.5% of patients still develop venous thromboembolism. So how can this be explained? Clearly, thromboprophylaxis, contrary to much of the public assertions, are not 100% effective. At best, we are seeing a 50 to 60% effectiveness, and we still have a very high thromboprophylaxis failure rate at a local level when we look at the cases of hospital-associated thrombosis. So we need to better understand the balance between VT and bleeding. Bleeding risk is, of course, much less well described, but influences the outcomes very significantly. And thrombosis, on the other hand, might occur when at an individual level, the threshold for VT is crossed, usually due to a combination of multiple risk factors. So we need to understand the heterogeneity of the patients, as well as both with regard to VT and the bleeding risk. And we need to refine the approach to thromboprophylaxis, where currently we seem to have only kind of one size for all the patients, across the modalities. So aspirin is being resurgent now, and we are waiting the studies of the PEPPER and the EPCAT-3 studies, which are looking at aspirin as the sole thromboprophylaxis. So we have a one-size-fits-all approach to thromboprophylaxis. So how can we further lower the risk of VTE? If we manage to successfully identify the patients who might benefit from more anticoagulation, and then there's a larger majority of patients in whom we can withhold thromboprophylaxis or provide less intense approaches such as aspirin. So just sharing with you modeling of this risk. And, with an individualized approach to prophylaxis using current strategies, you have 22.5 complications out of 1,000 patients. If you intensify the thromboprophylaxis, get more bleeding, fewer clots, but still the same number of complications. However, if you stratify using the VTE as well as the bleeding risk, then you can identify, say, 1 in 5 patients as being a higher risk cohort. And thus, those patients might benefit from either longer duration of prophylaxis or a higher dose of anticoagulation, saving the 800 lower risk patients from the cost and the burden of thromboprophylaxis. So to take this work forward, there's an urgent need for developing a well-performing, validated prediction model, as well as work on what an intensified anticoagulation regimen might look like. So just to end with now, and much to Beverley's disappointment, I'm sure, because she's fed up about COVID and WIT, but no talk on VT risk would be complete, I think, without a mention of the very considerable risk attributable to COVID-19, particularly severely affected patients. Clearly, the NICE guidance is that all the patients admitted to hospital should be considered at the risk of VTE, and we should just assess the risk of bleeding. But we do also know that the risks are dynamic during the course of the patient pathway, and that both the thrombosis risk and the bleeding risk might alter. There seems to be a need to adjust the intensity of anticoagulation to align to the degree of inflammation and bleeding risk. And I think COVID-19 exemplifies the inadequacies of a standard one-size-fits-all approach to thromboprophylaxis, where this immunothrombosis, I think, has accelerated many aspects of thromboprophylaxis research that we might look to apply outside of COVID-19. And I think one of the very important findings is that the type of anticoagulant matters and the dose of anticoagulant matters according to where the patient is in their journey in a hospital or after discharge. So in conclusion, prompt, accurate, and repeated risk assessment remains the key to VTE prevention. The GIRFT survey shows a considerable variation persists in VTE prevention practice, and that it's important that we continue to work on improving and validating the risk assessment models. And I think COVID-19 has highlighted how important venous thromboembolism is in this setting. And I think the optimal approach to thromboprophylaxis has yet to be defined. Many gray areas remain, which are largely evidence-free zones, psychiatric institutions and nursing homes. And I was delighted to see that Thrombosis UK had one of the webinars focusing on the psychiatric setting last week. So I think I'll stop at that point and acknowledge, to end with my many colleagues, that it has been a pleasure to work with in this setting, the GIRFT team particularly, and of course, Lara Roberts at King's and Banner Nemeth in Leiden, who were responsible for doing much of the work that I've described.
Well, that was fantastic, Roopen. Thank you very much. That was brilliant. It really has summarized where we are. If we were to throw in a better anticoagulant, such as we hope we might be able to in a year or two, would we have to start out all over again?
I think it's we have seen a complete shift, in the past 10, 15 years from, I remember we had those exclusion-based protocols in medical patients in which we gave all of them thrombosis, towards, individualized risk assessment using risk assessment tools, which to my mind are probably over complex now and not fit for purpose. To now, I think we need to refine, what is the smaller subset of absolutely important risk factors, and so narrow down that small group of patients that would benefit from either a more intense regimen, and we found, I think, one of the benefits, if benefit is how you class it, of COVID, is it really has accelerated this area of research into thrombosis, that the choice of anticoagulant matters and the dose is absolutely crucial.
Thank you. So, but if Helen managed to find a perfect anticoagulant with virtually no bleeding risk, we would relax, wouldn't we, and pull back and not worry so much about dose and side effects.
And particularly, I think, in the surgical patients in which, I think unfortunately the direct oral anticoagulants have had a very limited impact due to the suspicion amongst the surgeons that prevails about the wound infection rates and the bleeding rates, even 10, 15, 20 years on.
But I think that the changes in surgical and anaesthetic practice over the years have meant that we have had less clots. We get the patients in and out of theatre very fast. They get mobilised quickly. They're well hydrated. So the background risk of VTE has dropped considerably, but unfortunately you are doing more complex procedures, which often take longer.
And almost being heretical for a hematologist with enthusiasm for anticoagulants, maybe aspirin does have a role for the lower risk patient groups, as demonstrated by EPCAT2, either in a hybrid protocol or even as a sole approach for the lower risk group. So.
Good. So Narayan, what's your take on the current situation in 10 years' time, when we want to look at someone with a viewpoint of saying, do you have a pulmonary embolism? Where will we be?
Yeah, so I think we can't help but think that imaging will still be a crucial part in that diagnostic algorithm, but the type of imaging I expect would change massively. I think whilst CT remains very usable at this point in time, there are not insignificant risks to bear in mind. So the advances we're going to see, I think, are going to be along the lines of using cross-sectional imaging with much reduced radiation burden, making it smarter, using the next evolution of dual energy techniques to give us the structural information we need. And in that sort of field, I think there's evolution in MR techniques as well, which would allow us to get the same information but without the ionizing radiation. But I think that the additional aspect would be the functional information that we require. In basic sense, how new or old the clot is, what the consequences of the pulmonary embolism are, both at that point in time within the first 30 days, and is there a consequent likelihood of predicting what that consequence of that PE is going to be 1 year down the road, 5 years down the road. And I think those are real nuanced information, which I think imaging will provide in a much more smarter, safer way. So I think that's where it's going to be. Techniques like ventilation, perfusion, and imaging are hugely exciting at this point in time, and I think we're going to see the iterations of that where they become much more of a mainstay in imaging. That's where I think it's going to go. It's going to be safer, more reliable, and beyond the structural information, give us real functional information about clot.
But how are we going to get there? I think one of my disappointments over the years is having worked with MR direct thrombus imaging, seeing how wonderful it is for a DVT, but how disappointing it is to look for pulmonary emboli, because it really would be a great way forward, especially in situations like pregnancy. Do you think there'd be better resolution on MR?
Yeah, I think, and Professor Philippou touched on this in one of the questions she's posted. There's an area of research which is looking at radio labeling fibrin and using that in combination with MR imaging techniques to see if we can locate thrombus in a better way. And certainly the in vitro and animal studies have been hugely exciting and promising. And the fact that both the radio labeling process as well as the imaging techniques advancing hand in hand make that a hugely exciting potential area of use in pulmonary embolism, which poses challenges in diagnosis that we know.
Thank you. And last but not least, Helen, would you like to end and predict for us when you think the perfect anticoagulant is going to emerge, if ever?
Yeah, well, I mean, ideally it would be within the next decade, we will have anticoagulants that we can prescribe with not lack of concern for whether we're going to achieve efficacy and with minimal risk of bleeding, that will enable a single dose to actually be effective in all patients.
Okay, so I can remember in the 80s, Sam Machin, who was professor of thrombosis and hemostasis at University College, being on Tomorrow's World and saying in the next 10 years, we'd have the perfect anticoagulant. So Helen, I hope you're right. I think, yeah, maybe you are this time, but I think we were naive at the time to think we could move that fast. Okay, well, thank you very much, all three of you, for a really stimulating session and summarising where we are and where we might be going in the future. And please come back again next year and let's have another very similar session.